2020, the World Health Organization declared COVID-19 as a global pandemic. Many countries and health systems were unprepared for this outbreak, leading to its widespread loss of lives and the global shutdown. 3 years into the pandemic, we are reflecting on the challenges experienced during that time and the lessons learned and how to better prepare ourselves for future health crises. It's my honor to introduce our moderator today, Tiku Banda. Tiku was a GHC fellow in 2018-2019 in Zambia and was placed at the Center for Infectious Disease Research in Zambia as a pediatric HIV program officer. As a public health specialist, she has 8 years experience implementing infectious disease prevention and management programs in HIV, TB, cholera, and COVID-19, targeting HIV positive adolescents, adolescents living with disabilities, youth, and women. Ms. Banda has co-investigated a number of research projects focusing on health policy and systems research, COVID-19 and sexual and reproductive health. She is currently working as a community engagement expert on a Wellcome Trust-funded project aimed at improving the management of urinary tract infections among women in Zambia. Ms. Banda is a 2022 Mandela Washington Fellow alumni, a 2018 Global Health Corps Fellow alumni, and part of the Women in Global Health Zambian chapter, where she serves as a research coordinator. She has a master's degree in public health, health policy, and management from the University of Zambia. She also holds a Bachelor's of Arts in Development Studies from the same institution. It's my honor to introduce you, Tiku. Over to you to introduce our panelists today.
Thank you so much, Anita, and hello, everyone. Glad to be here, and I'm glad that you could join us today. As Anita has mentioned, my name is Tiku Banda, and I'm pleased to introduce our 2 panelists today, joining us to discuss this very important topic on public health lessons learned from the COVID pandemic. So I'll start. I don't know if Douglas, you are ready with your mic. Are you good to go before I can start the introductions? Douglas? Yes, so I don't know how we proceed from here, because we seem to have a technical challenge with one of our panelists, Anita.
Tiku, you can start us off with the introduction. Let's see how we can try and support him.
Okay, all right, thank you. So I'll start off by introducing Selom Kutsaiti, who's a public health physician who works as the Municipal Director of Health Services for the Ga East Municipality in the Greater Accra region, where she provides technical guidance on health, coordinates activities to control priority diseases such as TB, malaria, and HIV, and implementation of the maternal child health and nutrition programs. Her interests are health system strengthening and performance monitoring and evaluation. She has a bachelor's degree and a medical degree from Kwame Nkrumah University of Science and Technology, as well as a master's in health policy, planning and financing from the London School of Hygiene and Tropical Medicine in collaboration with the London School of Economics. She was a 2018 fellow of the International Program of Public Health Leadership, Cohort 2, led by the University of Washington's Evans School of Public Policy and Governance in association with the Center of Creativity Leadership, which was sponsored by the Bill and Melinda Gates Foundation. She was also a 2017 fellow of the Emerging Leaders Training Program at the Young African Leaders Initiative. Selom, welcome to our webinar today.
Thank you, Tiku.
And we also have on the panel Douglas Manganda, who is currently working as the Health Technical Advisor for Infectious Diseases at the GIZ National Office. Prior to his current role, he worked with the Ministry of Health as the Quality Management Officer, Monitoring and Evaluation under the Quality Management Department. He also worked at Palombe District Health Office under the Prevention Department, where he served as the District Integrated Disease Surveillance and Response Coordinator. He has also worked with the Malawi Liverpool Trust Wellcome Trust, where he served as the technical assistant. Having served in different roles in public health for over 8 years, he has given him the opportunity to accumulate experience in epidemiological investigations and humanitarian work. He loves organizing and getting things done, and also enjoys the company of good friends. And sports is his huge passion. So welcome, Douglas. I don't know if you're able to hear us and join in. Douglas?
Yes, I can hear you.
Okay, great. Thank you so much. So it has been more than 3 years since the outbreak of the COVID-19 pandemic. Since then, millions of lives have been lost and daily life has been unattended in countless ways. The pandemic exposed and highlighted the gaps in many public health systems. However, through the management and control of the pandemic, valuable innovations emerged and many lessons have been learned. In today's discussion, we will discuss about the public health gaps identified during the COVID-19 pandemic, the strategies taken to address them, and the lessons we can learn to better prepare for the future pandemics. In the 3 years of the COVID-19 pandemic, many public health gaps have been witnessed. So to kick us with this discussion, let's go to each of our panelists to share a little bit about your work in the COVID-19 response and the public health gaps you have witnessed in the response to the pandemic. So let's start with you, Douglas.
Thank you so much. Can you hear me?
Yes, we can hear you.
All right. Thank you so much. And it is my pleasure to have this discussion with the wonderful audience. I look forward to you guys to have a very good session. Whenever you have a question, please throw it in the Q&A chat. We will be able to respond. As you have read about my background, I'm a public health officer by profession. So I am privileged to have worked in the remote area as well as at the national office where I'm currently working. So I'll share about the experience that I had when I was working in a remote area in Palombe District Health Hospital. It's a hospital that is in one of the hard-to-reach areas in Malawi, in the southern part region of Malawi. The area is usually hit by floods. So we were surrounded by a community that is vulnerable to disasters. And also, when it's a hard to reach area place, the place is always almost like neglected. So one of the issues that I found out about in the COVID-19 response was the lack of capacity by the healthcare workers. Despite the fact that COVID-19 was a new disease, but when we started registering cases, it was so difficult for the hospital staff to respond to the COVID-19. When I talk of lack of capacity, I talk of one, lack of expertise. Because during that, you should remember, we had to call, for us to confirm COVID-19, we needed to do some testing, collect samples. At that particular time, we literally had nothing, no sample collection bottles. And for us, we didn't have the capacity to process the specimens. So we had to collect them and send them to another district, which was like somewhere around 90 kilometers. And it would take more than 48 hours for you to get back the results. So even if you had to put someone else, in quarantine, or you're waiting for the results, it was so difficult for you to move forward with the interventions. So we didn't have that capacity. On top of that, we also didn't have the knowledge on how to manage COVID-19 patients. And it took a while, close to somewhere around 3 to 4 months for health workers to come in, to know what to do. But at the beginning, it was so chaotic. So yeah, that's my experience.
Thank you so much, Douglas. And yeah, it's interesting to hear how I think the challenges that we're facing in Zambia were quite similar to to the challenges that you experience in your country, particularly with regards to lack of knowledge on how to manage COVID. As you've said, it was a very new disease, and I know I speak for most of the people on the call that a lot of countries within Africa did not know how to manage COVID. Salome, with your experience as a public health physician, are you able to share more of your thoughts with regards to how you and your country managed the COVID-19 pandemic?
Thank you very much, Tiku and Douglas. And I would say that Ghana was like everybody else. We're like deer in the headlights. We saw COVID coming on the TV, CNN, but nothing was done till the COVID arrived, literally. There was no preparedness on the ground. We hadn't trained staff. We didn't have any protocols or anything in place. Of course, it was a new disease. We didn't have even the structure of what to do. When you hear COVID, it was hysteria and a lot of noise. Everybody was running away from COVID. But the health workers were expected to run towards the COVID. So that was another issue we had. And then also, we had a lot of duplication of effort. So central government was doing something, local government is doing the same thing. So you have, everybody is trying to do something. Everybody wants to be seen to be doing something. And that led to a lot of duplication of the effort. And that's, that becomes quite redundant, because then you, the one who is supposed to be working, you are wondering whose instruction am I taking? Because you are all telling me different things. Which one can I take at a go? And then also, I would say that the COVID highlighted the lack of investment in public health activities, because for Ghana, for instance, our port health was very poor. Apart from the main airport and the main ports, seaports, all the other land ports didn't have any much port health activities. And of course, COVID was an import. So port health became a very important thing. And it showed that really we're not really investing in public health. We didn't have enough lab capacity. At the beginning, there was only one lab that was doing the tests. And you can imagine, everywhere I work in the city. And Douglas, you were taking 90 kilometers to get to your place. We were probably taking about 5 kilometers, but our results were taking 2 weeks and 3 weeks to come. So imagine you take samples, and then you're expected to keep the people in quarantine. You have to get people to isolate themselves, and you don't have results to work with. That was an issue. And then also, a lot of the public didn't seem to know much about anything to do with health. In their mind, everything health was when I go to the hospital, then I'll just go and get care. But beyond the hospital setting, people didn't realize that health impacted so much in their activities, because with the COVID came closure of schools and banks closed. A lot of things that we thought were day-to-day activities all ground to a halt. So the public really realized that health was not just what they thought. For us at our end too, another thing that we had to do, at least within my setting, was that COVID came, and then the public health staff were supposed to. So public health staff are doing case detection, they are doing contact tracing. This same staff are doing home care for mild cases, enforcing quarantine, arranging for people to be taken from the house to the hospital if their cases are severe. The same staff are to inspect schools to make sure they are adhering to COVID protocols, and when the vaccination came, it's the same staff who are doing it. So it's like the same few staff were doing everything. And sometimes the staff become very demotivated, because what's the use of telling me to go and do all these things? And I'm having so much to do, but the other people on the other side, the other health staff who are not pure public health staff, didn't seem to be under so much pressure like the public health staff. So for me, that was something that we noticed with the pandemic. Thank you.
Yeah, thank you, Salome. And yeah, again, very interesting to see, again, a lot of similarities within even the Zambian context, because I think when you talk about lack of laboratory equipment to detect COVID, we had that within the Zambian setting, because we only had, in the beginning, only within the Lusaka district, which is the capital city, only one major facility that could test for COVID. And I don't know if it's similar in Malawi and Ghana, but within the Zambian context, it was quite expensive to test for COVID. And there's a lot of monopolization of the testing of COVID within the Zambian context, which really, I think, affected the case detection within the country. And we saw a lot of people dying from their homes or from other maybe traditional healers, because there wasn't so much laboratory support that was able to detect COVID in the Zambian context. So coming back to you, Salome, how do you feel some of these gaps and challenges that you've talked about, such as limited knowledge for public health staff, the overuse of community volunteers to test and go out in the communities, as well as the lack of laboratory equipment, have been addressed so far in Ghana?
I'll say the COVID has helped us, because since COVID came, the capacity of some of the labs have been improved. Even the private labs now are able to do certain tests that previously they were not interested in doing. We also have a better investment in public health activities. So now there seems to be a bit more funding for even conditions that come, because since the COVID came, Ghana, for instance, we've had a Marburg outbreak, we've had Lassa fever, and for that there seemed to be a bit of support for case management and things like that, which was not what would have happened previously. Also, with regard to port health, there's been a bit of investment in that. So quite a number of our land ports have now got specified port health places where they have staff stationed who can actually undertake port health activities. And even with the other conditions that have come after COVID, like the Lassa I was mentioning, and then the Marburg, there's been better training and coordination. So once they detect a case, or there's a case detected in the West African sub-district, in the sub-region, sorry, a letter will be sent out that we have something happening in the West African sub-region. Everybody should look out for it. And if immediately they confirm a case, within a few days, some training is happening. There's a Zoom training. Come and learn, put your teams in place. Your public health emergency committee should be activated, all that kind of thing. It has actually helped us a lot. Previously, there was a lot of foot dragging, but now things are better. And the public is better engaged in participating in activities that benefits their own health, because they realize that health impacts on things they didn't even realize it would impact on directly. Thank you.
Thank you, Salome. And Douglas, what are your thoughts on how some of these gaps have been challenged or addressed?
I think from a public health perspective, a lot has been done. I'll give an example of here in Malawi. As a country, I think with the coming in of COVID-19, it has helped us to be a bit structured in our epidemic response. As initially we didn't have any platforms, any structure. We had to see the politicians coming in, the president himself, establish, bringing all those key players, both technical and non-technical people coming out, forming a team and coming together and strategizing on what to do. And also as the hospital, things have also improved. You've seen that some standards, people were trained, for example, in infection prevention and control, at least some baseline information or standards, guidelines, people, they know what, at least they have the foundation than before. And even as individuals, I must admit that during the COVID-19, it was the time when we saw that people were practicing the most smartest hygiene practices that ever before. You literally go into a bank. Before you go into a bank, you need to have a mask. You need to wash your hands. You go inside, you come out, you wash your hands everywhere. So I think that's a culture that was there before. So I can only imagine that the children that are born in this generation, I think they have some of these good practices implanted in them that they can be able to carry on, a thing that we never had before. So, and even psychologically, when the COVID-19 came in, there was all lockdown, people were in isolation, people started to adapt, we started to know and understand technology much better, talking of issues of Zoom. Some of the people were locked away from their loved ones, their families, but they were able to be there for each other psychologically using other means. So it has given us another opportunity for us to explore other avenues that we never did before, which is sort of like a blessing in disguise. But all in all, it has helped us, one, to figure out our gaps that were never there before, also to improve as countries, as regions, but also as individuals. So in that way, I think we have the foundation, the basic knowledge. All we have to do is now to build on them. Standards that we set, we oriented or trained, we have to make sure that we are able to maintain and sustain them. And I think in that way, things will be able to move in a better direction. Thank you.
Thank you, Douglas. And I do agree. I feel even within the Zambian context, we saw a lot of digital innovations come to play because of COVID. So I'll give an example. I was working at the time in the adolescent sexual reproductive space, and this entailed strengthening youth-friendly services in government-supported clinics. So one challenge we had because of the lockdown was that the health facilities were restricted. So not every person was allowed to go into the clinics to access sexual reproductive health services. So what we did with my organization then was develop a digital platform, a mobile app for adolescents to access sexual reproductive health, to get mental health services, and just know some of the community pharmacies that are nearby that can provide some of these SRH services. So I do agree that COVID in a way did provide this innovation in terms of digital health within a lot of countries. And also, just as you mentioned, around hand washing practices. So similarly here, we had a lot of cholera outbreaks before the pandemic, but I feel with the COVID pandemic coming in, and because of the strict measures to always sanitize, Zambia did see a reduction in cholera cases within the country. And I think to date, we've only had a few cases, and these were only recorded, I think, early this year. So yeah, again, I think it was very interesting to see some of the outcomes of the pandemic that came out. So moving on, we know that health emergencies demand the coordination and collaboration between public health and clinical medicine. Yet these two fields are not always aligned to work collaboratively. During the COVID-19 pandemic, there were challenges in determining who was in charge of response to the pandemic. Public health personnel alone didn't have the capacity to address the catastrophic events of the pandemic. Yet during its onset, most of the responsibilities for the management and control of the pandemic was left to them, with limited or no support from clinical medical personnel. So Douglas, what do you think are the reasons for the challenges in coordination and collaboration between clinical medicine and public health as experienced during the COVID-19 pandemic?
All right. I think, in my opinion, what I observed was the problems were already there, and COVID-19 only made it worse. So we made to realize the problems that we had. For example, one of the issues that I noticed was the lack of coordination among the healthcare workers is due to inactive rapid response teams. Ideally, before the outbreaks, or even for the other outbreaks like cholera that we've been experiencing, Ebola, and et cetera, we were supposed to strengthen our structures. What I will emphasize more on the rapid response teams that are within the hospital setups. So it starts at national level. At national level, we have the emergency operating center active. And going down to the regions, districts, and the hospitals. So we had like inactive committee. So because what happens in these committees is that you have representatives from all departments. They meet frequently. They get to review their preparedness plans and their response plans. For example, you bring in pharmacy guys, lab guys, clinicians, nurses, and the surveillance guys. Everybody else who's very crucial. And nowadays, with the One Healthy approach, we are also taking on board the other colleagues from the non-healthy sector, like water, animal health. They're all coming together. So because there was no coordination, such coordination at every level of implementation, it was difficult for them to coordinate, because one of the issues that they have to address is by looking at the roles of each person in that structure or in that committee. So normally when you have resources, you tend to have simulation and drills. Like if you recall during the Ebola outbreak, we used to have those simulations and drills, and you do that and flag out all the gaps and challenges that you have in your system, and then you build on those. You keep on improving, and you never stop. So we had relaxed for a long time, and COVID-19 being a disease that is of international concern, posing threats to security and trade, we were caught off guard. So our structures were not active, so it was so chaotic. So it was so difficult for people to coordinate. So yes, that's the challenge that was there. No structure. All the structures, there were no structures, and the structures were there. They were not active. Thank you.
Thank you, Douglas. Salam, what are your thoughts?
I think I'll just build on to what he said, because he mentioned the rapid response teams, and that was supposed to have been the interface between the clinical and public health. But then, honestly, I'm not sure, apart from the lists that normally the hospitals would put as their members, there was anything on the ground. Nothing was happening with regard to those kind of teams. And also, the teams, even before the pandemic, they were not working together as a team. And I would say this, looking at the previous outbreaks that came before COVID, things like in Ghana, we haven't had cholera probably in the last maybe almost 9 to 10 years on a large national scale. But around those times, you realize that the cholera is being managed like in little silos. The hospital people are managing their own thing. Public health are doing their own thing in the corner. Nobody is really coming together. Outbreak investigation is being done by public health, but clinical medicine has no input into what is happening there. So basically, we're all in our 2 little silos trying to do what we could. And as Douglas said at the beginning, because there was so little knowledge about it, and those who were speaking were mostly public health experts, the clinicians, I think, felt left out. And they were speaking public health English. And public health English is not the same as clinical English. So obviously, the clinicians didn't really get what all these people were talking about with outbreak and what infection, infectivity. They're just like, why are the human beings? We don't have guidelines to work with. So then they said, okay, once the public health people are talking, let them manage it. But of course, our expertise is not in case management. We can help you pick the cases, but somebody has to manage them. So that was a big issue. And then the public health units, even in the health facilities, were not strong. In most facilities, they are supposed to have a public health unit where they have a certain complement of staff who are supposed to do public health there. But you realize that the staff there don't really do much. They're not, as compared to their colleagues outside the hospitals, they are not doing much public health. They focus so much on clinically related things. So those people also were not able to guide the clinicians when it came to doing what was needed to be done. And lastly, I would like to add that I'm a public health person, so I'm a bit biased, but I think that the clinicians didn't really appreciate the role of the public health people in pandemic management. Because, you can manage the cases and put them in a room and be taking care of them. But the issues go beyond just managing them and putting them in a room. There are other issues. There's a wider societal effect, and the clinicians don't have much impact there. And we seem to have a lot of impact there. So when this condition was no longer a hospital-based condition, this one was hospital/community. So it means that we were also important in managing this thing, not just the people who are sick or those who are seen in Italy lined up outside and being managed. Public health was important. And I thought that during the pandemic, our role was not, before the pandemic, I would say our role was not really seen, but now they realize that no, they needed to have us on board in doing whatever needed to be done, because you can have the COVID case, but you can't go and do contact tracing. You don't know where their house is. Is the public health people able to go and do all that work? Who can even go and identify if the patient the place is good for the person to be transferred home or whatever? We are the ones who do all that. Thank you very much.
Thank you. Yeah, very interesting discussion. I would like to differ a little bit from our end in Zambia, because I think there was some form of collaboration between the two. We saw for instance, the National COVID Task Force come into play within the Zambian setting. And in this task force, we did have a multi-sectorial approach. So we had the clinicians, the public health specialists, the community healthcare workers, the COVID nurses were hired. So it's really interesting to see the dynamics across the different countries within Africa, because I think for the Zambian end, we didn't necessarily have that challenge. And what we saw rather was different groups being set up from national, district, all the way to community level. And we had the COVID risk communication and community engagement task force that were also set up just to try and have these different facets of groups working within the different public health space to come in and provide information. And I think it was quite challenging in the beginning for clinicians, like you're saying, because first of all, COVID was very new and there was a lot of debates and there were so many theories on what COVID was. So I think the first quarter, I think, at least in the Zambian context, there was a lot of research, a lot of, back and forth on just agreeing some of the terminologies or the concepts of what were happening in terms of COVID. But I think after that, we saw a little bit of cohesion in terms of how to address COVID, how to make sure that everybody had sort of an important role to play within the COVID pandemic. But yeah, very interesting to see and to hear what was happening in both Malawi and Ghana. So moving on, what do you feel, Salome, should be done to ensure this cohesion between clinical medicine and public health?
I think a lot of work has already gone. With the COVID coming in, there's been a lot more emphasis on the two units working together. So I think that there has to be a lot more training and sensitization of the staff on the importance of both roles. And then also there must be the staff, the preparedness issues should not only be kept at the level of the public health, because previously when they talk about preparedness plans, typically the public health people prepare food preparedness plans. The public health people should work or are working with the facilities or the clinicians now to do those things. Also, when the clinicians want to do all their drills and things like that, the simulation exercises, public health is also on board. So for Ghana, for instance, after the COVID, we've had, I think, about 1 or 2 simulations for a viral hemorrhagic fever. They didn't specify which. And they showed us the results and we're all laughing because you see the public health people there, you see the clinicians there, but this time everybody was working together. It wasn't the public health people, there's a case for you, go to them this time. It was now like, what are we all doing together to get these things done? So I think the COVID has helped us. I wouldn't say COVID is a good thing, but it has been a blessing for me for public health. Yeah, in Africa, it has really helped us a lot because it has exposed so much and has helped us to work on improving our things. Thank you.
Thank you, Salome. And Douglas, what strategies do you recommend to ensure cohesion between clinical medicine and public health?
For me, my number one thing is that we need to not do business as usual. I'm saying this because now I sort of have 2 sides of experience in terms of response. When I was in the government side, and now I'm in the NGO. So when I was in the government side, whenever we see actions, we meet partners, all we were requesting was we need trainings. And now when I've moved into the other side, I'm a partner, I see that I see no impact of these trainings because, for example, we had Ebola, we did a lot of trainings, capacity buildings, contact tracing, etc. And cholera came in, the same trainings, have the fundamentals, the basics, which can also be replicated in other epidemics, for example. And then COVID-19 came, we replicated the same, and now in Malawi we have cholera. We also the issues of trainings keep on coming. So, in my understanding, we need to do things differently. For example, if we do trainings, we need to put in measures to ensure that knowledge has to keep on sustaining and also be shared to other healthcare workers that are coming in. including pre-service training. For example, clinicians, physicians, health workers that are graduating from colleges, you will see that for those that are graduating now, they end up not knowing how to manage COVID-19, and yet it's a hot issue at the moment. So if we to include those issues in pre-service, I think it also do us good. And then when we go out in the hospital setup, I'll go back to the issue that I mentioned about rapid response teams. We need to strengthen those, because up to now we have some areas, districts where these structures are not functioning, and all these issues are only healthy related problems. So when we strengthen them, we'll end up bringing everybody else on board, and they'll be part and parcel of the solution, and we'll be able to move together. In that way, we will sort of improve, because we have cohesion in our preparedness, in our plans, because everybody will have their role to play. In that way, I think things might improve. Thank you.
Thank you, Douglas. And yeah, I do agree that there is continuous need for capacity building for countries in Africa to be prepared for emergency response. And I think the COVID pandemic itself is a very huge lesson on how unprepared we were, even as Africa, to just respond to these emergencies, despite having seen examples of Ebola and cholera. So moving on, political will played a very important role in the management of the COVID-19 pandemic for many countries. And while some governments took heed of the epidemic early and adopted preventative public health initiatives, thus minimizing the spread of the pandemic, other governments didn't have this, and this came at a very high cost of lives. In your opinion, Salome, what is the role of government in a public health crisis like the COVID-19 pandemic?
So the government for me has two roles, and I'm looking at Ghana. I use Ghana as an example. Our president was like on top of the COVID. Every Sunday he would come, and his favorite word was fellow Ghanaians, and he would tell us something about the COVID. So first of all, there should be leadership and coordination at the level of the government. They should coordinate all activities. And the government is not just the central government. This should also come down to the level of the local government. I think I mentioned earlier that there was issues of duplication. Central government is doing something, local government is doing something, but there should be some level of coordination from the government in regard to handling any pandemic or any outbreak. The second thing has to do with resource mobilization and allocation. For us in Ghana, at the beginning, we had nothing. Then later on, we started having things. So we started producing cloth masks in the country, sanitizer. Then it came to a point we had too many of things. So we're flooded with cloth masks, we're flooded with sanitizers nobody would need. So there was the resources were mobilized, but I don't think that the way it was allocated or the way it was being planned for was, I would dare say, the best, because we end up wasting so much money on things that we end up not needing. So government needs to lead and coordinate all the activities and also look for resources. So government will get money to get the reagents for the COVID testing. Government will have to go and produce money to set up isolation centers. Government will have to make sure they are getting, because COVID was supposed to be free. Treatment is supposed to be free. I emphasize supposed to be free, because certain things government is supposed to provide, but governments at a point, oxygen, people are paying for it in certain places. People are paying for certain adjunct medications for the COVID in certain places, which also was not the best. But ideally, once it says, government says, I will take care of it, it should be able to be done and done properly. So for me, those are the two roles government should play. Thanks.
Yeah, thank you, Salome. Douglas, what are your thoughts on what you think the role of government is in a public health crisis like the COVID-19 pandemic?
Echoing from what Salome has shared, I think the politicians, the government has to be more upfront in coming in to respond to COVID-19 or any other epidemics. For example, I liked what the president of Malawi did when we were introducing the COVID vaccine. So it was officially launched. It was a national event where it was everywhere else across the country. They were launching it officially. and he got vaccinated in front of the camera when everybody else was watching. So these politicians, they have so much impact on what they do or what they say as they a lot of people in their communities. So they have to be more upfront. And on top of that, they also, Salome mentioned about the issues of funding. I feel like here in Malawi, I think they didn't do a good job. For example, we were supposed to declare a state of emergency quite a long time ago, but they took time to do that. Because when you declare a state of emergency, you also sort of like informing the whole world that we have a big issue at hand. We need all the support that we can get. So I think it took them a bit of a while to do that. So I think they just need to fast track and be upfront of everything else and do that. Another thing is also the funding that she mentioned. I feel like as a government, they can influence some immobilization of resources. For example, the issue of vaccine. We all know that vaccine during at that time COVID-19 vaccine, it was sort of on a high demand. But when the government officials understand the fabrics of the need, they come in and help to lobby and push for those processes to be very quick, and they are the only ones that can be able to influence or to outsource or to mobilize such kind of resources. So they have a very big role to play. Thank you.
Thank you, Douglas and Salome. Yeah, I think both points are very important, and I do see how most governments, at least initially, tried to garner support from the private stakeholders. We also saw a lot of government leaders just showing that leadership in taking the first step to vaccinate against COVID. I'll give an example. Within the Zambian setting, we saw a lot of private sector coming on board to donate resources, or in form of finances, equipment, PPEs, etc. And I think the transparency that the Ministry of Health in Zambia showed was very encouraging, because I think these were televised live on TV for the first, I think, 2 or 3 months. And we saw how a lot of stakeholders were coming on board. But unfortunately, our Ministry of Health did misappropriate most of these donations. And I feel that was one of the downfalls in Zambia when it came to COVID-19 response, because I think a lot of people in the public lost trust in our government. They lost, a lot of people thought it was a money-making venture, for lack of a better word. So whilst they did show leadership in the first few months, that leadership was quickly overturned by a lot of corruption reports that came out from the public and from different reports, audit reports. So maybe just to get a quick feel on what was happening in Ghana and Malawi, how did you feel your governments manage the COVID funds or donations that they were receiving, if at all there were any donations? Maybe under 1 minute. I'll start with Salome.
I think the sentiment of COVID becoming a money-making venture is probably across the whole of Africa. For us, we had the private sector setting up our first infectious disease center. They built it from scratch. So that was a big thing for them. They purchased cars, equipment, ventilators. They even set up an oxygen machine and things like that. We had some of the international organizations setting up facilities for the public sector. But as time went along and as various audit reports have come out, there are things that sometimes you just, some of us still work for the government. So there's certain things that came out and, it made things a bit, you feel in a way used. Most of the staff were in a way feeling like they were used because they went into this pandemic blind. At the beginning, there were no masks. People were just going out, doing what they need to do. And then the thought is that, so if I had died, I'd have died in vain, because people have made huge sums of money off it. The government did quite well at the beginning, But along the way, I don't know, technical knowledge and technical guidance was sidestepped, and a lot of it became now at other considerations outside what was actually health, was a health consideration. The considerations that came in that were running the day were no longer about health. They were about other things. And now that is what I would say, that's for COVID. We don't want to talk much about it. It has helped us, but we don't want to talk about. Some of us still work for government.
Okay. And Douglas?
Yeah, I totally agree with Salome. The COVID-19 funds were politicized, to put it that way. They were politicized, the way the government was looking at it, it was from the political point of view, because even when
we seem to have lost
look at
Douglas.
the structure. Yeah. Okay, can you hear me?
Yes, we can hear you now.
Okay, yeah, I was saying that the approach was more of political. So even when you look at the composition of the presidential task force, you would see that it was composed with a lot of politicians and few technical people. So for the technical people to influence, it was difficult. So even if they would make good recommendations, but they were overshadowed by the police.
Okay. I think we've lost Douglas again. Douglas, are you there?
That's the only challenge. Yeah, sorry,
okay.
My point, yeah.
Okay, and lastly, to Salome and Douglas, what measures are there to hold, or do you think, in light of what we're talking about, what measures do you think are there to hold governments accountable to proper manage future pandemics like COVID?
All right, I'll start. Number one is to have proper structures. So here's the thing: we have very beautiful policies, paperwork that is out there, and it's so beautiful and colorful. But for us to institutionalize whatever we have put out there, it's a bit challenging. So I'll give you an example. Here in Malawi, we've had cholera for the past 20 years, but up to now, on how to manage cholera. Okay, a 5-year or 2-year strategy. So I was surprised when we early this year, when we were at the peak of cholera, when districts were reaching out to the ministry, like, we need guidance and direction on what to do. The cholera cases are so high. I was surprised, like, even the government the ministry officials doesn't have they don't have all the plans in one place. So I think number one is to make sure that all those documents that we have, we should institutionalize them. Another example is that, for example, in Malawi, we implementing we use the health service strategic plan. We started with the version number 1, number 2, and now we're in number 3. When you look at those plans, issues of epidemic preparedness and response are not there. They just talk about HIV, TB, nutrition, etc., but or reproductive health issues, but issues of preparedness are not there. So even if you no matter what you do, if you plan at the national level, it's difficult to implement them. So that's number one. So when we have those structures in place, we also need to have people that will be held accountable, because if by the end of the day, we need to ask, Salome, you were assigned to do ABCD. What happened? And then Salome will be responsible for that. She'll be held accountable by the end of the day. So we need to do that. And another thing is that we need funds. So there's this thing that during an epidemic, you don't have resources for preparedness, but only for response. So that's a challenge. There are all these climate change interventions, that will help to address some of the challenges, but they are not implemented. Even in research, that is not done, but only when there's an epidemic that are very activated, are very much activated and out. So if we are to also sort of create a balance where preparedness activities are also taken on board and prioritized, I'm thinking that these things will move better. Thank you.
Thank you, Douglas. Salon, what are your thoughts on some of the measures that can be put in place to hold governments more accountable in management of public health pandemics?
I think Douglas has spoken quite a bit, and my emphasis will be on the first thing he said, which is let's adhere to the things we have it put in place. We have Public Health Emergency Management Committee. We know the structures for that. We have rapid response teams. We know the structures for that. Everybody knows their role. So people should be accountable for their role. So if something goes wrong, then we know that the weakness is in this level or that level. And then also there are issues around funding. Recently, we're doing some work on development of a guideline for monkeypox. We have recently just had monkeypox, and there was no funding for, as you said, no funding for preparedness, because we expect that the preparedness activity is part of the baseline public health activities. But generally, there's no funding for baseline public health activities. We are expected, they'll tell you earn a salary, so use a salary. But then the activity is not salary activity. Some of the things involve doing more than that, going out and getting certain things in place, but there's no funding for that. So there needs to be funding for that. And I think that when people are held accountable and actually sanctions are put in place, people realize, like in the West or in parts of Asia, where people died because somebody didn't do their work, people would actually, and consequences are okay, people would actually set up. But in a certain where somebody will die, we all watch, or we know what the problem is, something will happen. So many people will die from, let's say, cholera because there's no proper plan or system in place, and nobody is held responsible. Then we are literally just going back to what happened pre-pandemic. The pandemic was supposed to have been a wake-up call for us. So we are supposed to use it to improve our system. At least Ghana, I see a little improvement. It's better than it was before pre-pandemic, but there's still a lot that needs to be done. Thank you very much.
Thank you so much. I think we can go to our participants if there are any questions to ask the panelists in the few minutes that we have left on the call. Do we have any questions, comments? Okay, so I think Hannah has posted a question. So she's saying, what are some of the best practices you saw throughout COVID-19 for integrating workforce budgets and resources of healthcare? So we can start with Salome, then Douglas.
I don't think I saw integrating much. Everything was still kind of, in a way, silo-based, because there was funding for health promotion. So it's only health promotion funding for laboratory funding. There was not much with regard to integration. But the only best practice of this, I would say, is the staff. The staff themselves at the point realize that this is a do or die for the country. So we might as well just sit back and set up and then see what we can do to help our country. We don't want to turn into Wuhan or Italy or any of those countries you saw on TV. So the staff actually got up and did the right thing. And then there were one good thing we had in Ghana were triaging corners. So when you enter any health facility, you are triaged there. They ask the COVID questions about COVID. You have a station to wash your hand. If you had symptoms that were suggestive of COVID, you were treated at a separate place from everybody else. Those actually helped to reduce the number of people who were coming into the health facilities. And I would say one of the best practices I saw, which has come to stay, is the telemedicine. I think Douglas, either you mentioned issues of like digitalization. we had quite a bit of telemedicine initiatives coming in, and I see more and more of that in the private sector, because people are no longer so keen on getting up and having to go and queue in hospitals when they know that they can stay at home, because when we're having COVID, hospitals were closed anyway. Thank you.
Thank you.
Yeah, and maybe just to quickly dive in. In the first place, it was hard, as it was perceived as a healthy problem only. But with time, things started to improve. For example, we saw other players coming in. For example, those in the digital space, as Salome has said. They started coming in, the issues of telemedicine. So there was a toll-free line where people were coming in, were calling in for free, and they would get some medical assistance over the phone and some clarification of other myths and the misconceptions. The more we grew with the epidemic, the more we also started to understand and got ourselves organized, including the healthcare setting. It was so disorganized in the first place, but eventually we had, for example, the nurses and clinicians, they were organized in terms of their roster. They would have health workers who work full-time in their camps, and after that they'd go on quarantine, and others coming in, that sort of approach. But it was really challenging in the first place. But eventually we had other partners and other players that were unhealthy coming in and also playing their part.
Okay, thank you. And maybe a last question for you, Salome. I'm trying to, sorry, there's somebody that has just posted. Anita, are you able to help me read out the question? My screen seems to be.
Yes, there's someone who shared a question earlier, Crispin. Thank you for sharing your insights on the COVID-19 pandemic. The vaccination process has been identified as a significant strategy in controlling the spread of the virus. However, it has faced challenges in terms of access and vaccine hesitancy. As public health leaders, how can we effectively tackle these issues and ensure widespread vaccine access and overcome hesitancy among the population?
Okay. I think Salome can answer that. Yeah, in under 2 minutes.
Okay, so for us, vaccine hesitancy has actually become worse. Initially, we were having all the various myths and things. We did quite a lot of work. Our president was vaccinated live on TV for us. That was in March of 2021. And the next day, the national campaign started. We initially had a lot of problems with vaccines because we were always waiting for donations from outside the country and things like that. But now we have vaccines, but people are not taking the vaccines. That was because about last year, also our president came and said, people no longer have to wear masks in public and things like that. So then the population is interpreted as meaning that there's no more COVID. So that has also led to a new wave of hesitancy. Most of those who will take the vaccines are those who are actually, I would say, the more educated ones, the ones who tend to travel, and the ones pushing for the vaccine. But the main population is quite difficult to talk to them. But we are still trying. We do go out, we do house-to-house campaigns. In Accra, for instance, we have a campaign coming up in the first week of June, 5 days. We go house to house, church to church, mosque to mosque, everywhere. We go out with the vaccine, we try and convince people to take the vaccine. That's the best we can do because, I mean, there's no going back now. And I don't think the president will be willing to come back and say people should go and take the vaccine after how many years, like after being away for so long, talking about the COVID pandemic. So for us, we are trying at the community level, but it's not easy. Hesitancy is a very, very big problem. Now we don't have an access problem. We have vaccines, but people take the vaccines are now the problem. Thank you.
Thank you. And Douglas, maybe you can, you can answer the last question.
Unfortunately, we are at time. So sorry, we are at time. This has been a really informative, interesting, thought-provoking conversation, and we really appreciate your thoughts. Thank you again so much to our incredible panelists, Douglas, Dr. Salome, Tiku, thank you so much for such an informative discussion. And we really appreciate your insights, perspectives, and experiences that you shared on this call. Thank you also so much for our international program in public health leadership community that may be on the call, and for Dr. Salom, who's a part of that community. Thank you for being with us. We appreciate our collaborations. This is all the time we had for today. So thank you all for joining us and sharing your questions, and apologies for not being able to get to all the questions, but maybe we'll have a follow-up email where we can address some of the questions that have been shared. Thank you so much. We wish you a great rest of your day. For our GHC community, we will be sharing this discussion on the community portal for your later reference and review. So we wish you a good rest of your evening and morning for those joining us outside of Eastern Central Africa and Western Africa. Have a great rest of your day. Thank you.
Thank you.
Thank you very much. Bye-bye.
Bye-bye.